Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure of moderating today's tumor board. We have a very esteemed panel of individuals today with us, and so I'm going to ask them to each introduce themselves.
Hi, I'm Norman Womark. I've been around for a good many years, as perhaps some of you know. I'm chairman of the NSABP Foundation and one of the chairs for NRG Oncology and the contact PI for that group. And I'm professor of surgery at the University of Pittsburgh.
Hi, I'm Tom Buchholz. I'm a breast cancer radiation oncologist. I'm the medical director of Scripps MD Anderson Cancer Center and professor emeritus at MD Anderson Cancer Center in Houston.
Hi there, I'm Sarah Hurvitz. I'm at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. I'm professor of medicine and director of the breast oncology program there.
Hi, I'm not going to tell anybody how long I've been around, but I am the director of imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am primarily a breast imager, but I also do PET imaging as well. So if I come on a PET scan, it does come with a little bit of experience in the background. I am a member at Memorial, which is the equivalent of a professor, and a professor at Cornell Weill as well.
Thank you so much to all of you for joining us today. I look forward to learning from each of you. Our next patient is also quite young. She's a 38-year-old African-American female with metastatic triple-negative breast cancer to the lymph nodes, adrenal glands, and to the bone. And she's currently receiving Sacituzumab. What is the best choice for next therapy? So again, this patient noticing a palpable lump in her axilla, in the right breast in December of 2019. And then in January of 2020, a biopsy of the right breast and axillary lymph node were consistent with grade 3 invasive mammary carcinoma, which was triple negative and PD-L1 positive. A PET scan at that point demonstrated the right breast mass, as well as right infraclavicular, axillary, and internal mammary lymphadenopathy, as well as uptake in the left ischium. She underwent a CT-guided bone biopsy of the left ischium, which was consistent with metastatic carcinoma. And her germline testing for BRCA 1 and 2 was negative. At this point, she has a performance status of 1. Of note, she has a history of sickle cell anemia and is currently on hydroxyurea for management of that. She has had a cholecystectomy. She's premenopausal, G0, P0. Her father has a history of prostate cancer and maternal aunt diagnosed with triple negative breast cancer. Some other secondary relatives with malignancy, but of note, the genetic testing, at least the BRCA 1 and 2, was negative. Dr. Jockelson, do you mind sharing with us some?
No, I'm good at sharing. I was brought up well. Okay, so you can see fairly easily, she has very dense breast tissue, but her tumor is actually in the fat behind the dense parenchyma in the upper inner quadrant of her breast, the mass, which has a correlate on ultrasound. You can see that it's a vascular tumor, very thickened cortex, not much hilar fat. So fairly straightforward case. She had the CAT scan, which also demonstrates the tumor in her outer breast and in her right axilla, and the granulomatous disease in her right lung.
Perfect, thank you. So at this point, the patient from January to July of 2020 received 6 cycles of nab-paclitaxel and atezolizumab. Dr. Hurvitz, do you want to comment about that as the first-line therapy? Are you in agreement with that?
Yeah, nab-paclitaxel plus atezolizumab is based on the Impassion 130 study, which did show a significant improvement in progression-free survival by adding atezolizumab to nab, as well as an interesting improvement, though not statistically significant based on the study design, improvement of overall survival in those patients with tumor immune cells that are PD-L1 positive. So she appeared to qualify based on her PD-L1 positivity, and this would be the appropriate therapy for her to receive in that setting.
Great, thank you. In July of 2020, repeat scans demonstrated progression, unfortunately, with new cervical abdominal pelvic lymphadenopathy, as well as worsening of the right axillary adenopathy and the emergence of new adrenal and bone lesions. At that point, the patient was transitioned to systemic therapy with doxorubicin and cyclophosphamide between August and October. A repeat PET scan in October of 2020 demonstrated improving right breast axillary malignancy and bone metastasis, but worsening cervical adenopathy. At that point in time, she was placed on Sacituzumab, govitecan, which she remains on at this time, and repeat scans are planned after 4 cycles of Sacituzumab. So I might ask Dr. Hurwitz to comment on the treatment thus far, and then where would we go from here for this patient when progression invariably occurs?
It's really unfortunate when we see patients have their disease go through 3 full lines of therapy in fewer than 12 months. That is a very aggressive disease biology and is not, triple negative breast cancer, many would agree, is heterogeneous. There are some triple negative breast cancers where patients can live for many years and achieve good stabilization in their disease for many, many months or even years. And then there are triple negative breast cancers where the disease trajectory is progression after progression very quickly, which is similar to what we're seeing in this type of case. The treatment she's received is treatment that is very appropriate for cases like this. Frontline taxane with an immune checkpoint inhibitor if PD-L1 positive, use of an anthracycline certainly appropriate. To try that, I might use single agent pegylated doxorubicin in place of AC, but AC is perfectly appropriate. And then the recent FDA approval of Sacituzumab govitecan, which was shown in the ASCENT trial to improve not only progression-free survival and objective response rate, but also overall survival compared to single agent chemotherapy. Hopefully she'll have a better response to Sacituzumab than she has had, or a longer response than she has had to other agents. At the time of progression, this is really when I would be searching for clinical trials. Of course, we have chemo we can use, Eribulin, Vinorelbine, Gemcitabine, Carboplatin. There are things, CMF, which is an oldie but goodie. However, really clinical trials is, I think, where it's at. I would see if I could get the tumor genomically sequenced and look for targetable mutations that would qualify for her tumor for a clinical trial, AKT mutation, HER2 mutation. There are a lot of ongoing phase 1 and 2 studies. I'd be interested in knowing if if the tumor HER2 was 1+ or 2+, then there are therapies, antibody drug conjugates that are being developed for HER2 low expressing breast cancers. But this is another situation where I'd get on clinicaltrials.gov and put my feelers out to colleagues around the country and see what types of studies they have if I didn't have one for her.
Thank you.
Do you have the images for the, and not that they're all that important, except for the one in the corner there, as this is her diffuse metastatic adrenal metastases. This is another patient with multicentric disease in her right breast. But the reason I wanted to bring this case up, so this shows a cervical or supraclavicular adenopathy. And this actually was from a paper published by one of my former colleagues, Gary Ulaner, who was looking at her tracer for HER2. And this is a patient that had actually not had HER2 positive disease originally, and she was put on our protocol, and that node actually was picked up the HER2 tracer, and we biopsied it, and she had HER2 positive disease in that one node of note, but only because she heard, I put it in because it was a HER1 positive, and at some point when this patient got all of this terrible disease, the question is whether, that tracer is not out for use, but it's something that in the future we might be able to get an idea in a case like this when they're so young and nothing's working. And that particular node was the only HER2 disease, but it responded to trastuzumab and pertuzumab. So.
In this challenging clinical scenario, if there is progression seen after treatment with sacituzumab govitecan, we would recommend sending tissue for next generation sequencing. Perhaps this would identify an actionable or targetable mutation that could guide participation in a potential clinical trial. We also would recommend looking for mutations, somatic mutations within the tumor, such as BRCA or PALB2, which might allow for targeted inhibition with a PARP inhibitor, for example, as a possible therapeutic strategy. Of course, cytotoxic regimens are also available, particularly those mentioned in the discussion were Eribulin, Vinorelbine, and a number of others as discussed in the video by the panel.